Well, good morning. I'll start with my presentation. My name is Reinaldo Colon-Morillo. I'm a fourth year from the Naval Hospital in Balboa, and I'll be talking about thoracolumbar trauma and indications. I'll start with a case. Here's a 27-year-old male attorney with psychiatric history who jumped about 40, 50 feet from his balcony, came to the trauma bay, intubated to the SICU, still responsive. It had multiple lower extremity ortho injuries, status post-lint, which kind of hindered the neurological exam, but otherwise was unable to demonstrate any L4 through S1 motor, had no rectal tone or perineal sensation, and his had a Foley in place. Here, cross-sectional CT scan and MRI demonstrating kind of burst fracture with retropulsion into the spinal canal, compressing the fecal sac, and MRI demonstrating posterior ligamentous injury. So we'll go into a little bit of the anatomy and biomechanics in three specific regions in the thoracolumbar region: the thoracic spine, TL junction, and then proper lumbar spine. So the thoracic spine from T1 to T10, it's an inherently stable segment due to it being rigid because it's supported with rib sternum, has short disc, and also the coronal facet junction orientation makes it very stable with a relatively narrow canal. So whenever we have these injuries in the thoracic spine, they have higher rates of neurological injury given the energy mechanism that needs to be input in there. At the thoracolumbar junction, we'll see that that's kind of the most common one. It's for injuries because it's a transitional zone between a very rigid thoracic and a more mobile lumbar spine. And then as we go down into the lumbar spine, which is more mobile, you have kind of in the facet joints, it's more coronal as we go distal, and the pedicles they angulate more medially as we head down in the lumbar spine, with L1 being the smallest diameter in the L spine, overall T4 being the smallest in the spine. A little bit of epidemiology. It happens in like 160,000 spinal injuries per year here in North America. With, like I mentioned, the thoracolumbar junction is the most common one with more than 50% of injuries. As usual, usually young people, men, greater than female, these injuries. The mechanism usually is high energy mechanism, either motor vehicle accident or fall from height. I feel from my experience, most of the things that I've seen have come from the U.S.-Mexico border or motor vehicle accidents, just from San Diego perspective. And basically, 1 in 4 patients will have either some thoracic injury, which is in rib fractures or pneumothorax, intra-abdominal visceral injury. It's usually more at the lower thoracic spine, long bone fractures, head injuries, and non-contiguous spine injuries. So initial management, obviously, usually the majority of these people come through trauma bay. So ATLS starts the workup. Usually for the HPI, trying to understand if they had any mechanism of injury, if they can tell. Having a neck pain, back pain to see if there's a non-contiguous injury. Check for any neurologic symptoms, check for their posture, evaluate the full spine. And then the neurologics exam, obviously try to get an ASIA grading, but in setting of spinal shock, you can't give a spine grading. And then from the medical surgical history, obviously, if they have any dish or ankylosing spondylitis, have your spidey senses get advanced imaging because we don't want to miss these injuries. And then obviously check for non-contiguous injuries itself. This was actually a patient that I had seen that had come with vertebral body fracture dislocation, but had a non-contiguous burst fracture at the lumbar spine. Radiographs, obviously, like we're checking for alignment, rotation, if there's any height loss, any whitened interspinous processes that can determine if there's a distraction injury. And about one in four burst fractures can be Redis compression, and then obtaining advanced imaging can give an accurate representation of the fracture morphology. And getting into that, CT, it's what we use for characterizing fracture morphology, preoperative planning, evaluating if there's any bony canal compromise. And then MRI is more of a soft tissue to evaluate if there's any PLC disruption. As we get into the TLIX score, it's going to be something that's going to go into our surgical treatment criteria. So getting into the classification, Denis in the early 80s developed what was the three column theory, and where he had three columns, anterior, middle, and posterior, with four major types being compression, burst, flexion, distraction, which is our hands fracture, and then fracture dislocation, with several minor types. Anterior column being the anterior ALL, anterior third of the vertebral body, with corresponding disc annulus. Middle column being PLL, posterior two-thirds of the vertebral body. And then the posterior column, which has your spinous process, lamina pedicles, TPs, ligaments of flavum, interspinous and supraspinous ligaments. Because this kind of criteria classification system didn't really emphasize, a lot of different classification systems have been developed along the way, which really most of them just said they talk about what the fracture morphology is. No classification system was giving a kind of treatment pattern regarding the fracture morphology. So McAfee and Ferguson Allen, again, trying to describe it in terms of the fracture morphology itself. Then came the AO classification, the very basic AO that got further defined later in the 2013, which had compression as your type A, B, distraction injuries with ligamentous or ossicular ligamentous injuries, and then C being multi-directional. Then in 2005 came the where the TLIX score came out of the spine trauma group, which this classification was based on the morphology of the injury, the integrity of the PLC, and the neurological status of the patient, where points were assigned to each category, and then the final total points recommended a treatment plan in which less than 4 being non-operative and 5 and above being operative, and then 4 it's kind of surgeon's choice regarding the surgical treatment plan. And the two most important considerations for this that not the prior classification system did not take in consideration is that PLC integrity. This article also talks about the surgical approach. Should you go anterior, posterior, or combine? And for anterior, what they were discussing was that if they had incomplete spinal cord injury, if the neural compression is present before attempts at postural or open reduction, and then posterior, usually if there's any kind of PLC disruption, and combine anterior posterior if there's anterior compression with spinal cord injury, and then also a PLC injury. So the conclusions from the original TLIX score said, hey, this is what we propose. We need to make sure this is reliable. And then 4 or 5 papers have come out kind of validating the TLIX score, except this study that was published by Dr. Moore that said for that the maintenance of lordosis and the global sagittal alignment is paramount when dealing these low lumbar injuries and are not considered in the original TLIX score. So they said that for L3 and below, they tend to, for L3 injuries, they tend to behave like thoracolumbar injuries, and there's wide variation from L4 to S1. Then Dr. Joachim in 2014 presented basically clinical results from the TLEX score, where they wanted to check if the neurological outcomes of patients with thoracolumbar spine trauma treated with the TLEX score, if they had any worsening of neurological injury, where their primary outcome was their ASIA score. And then they concluded that there was no patient that had any worsening during follow-up regarding their treatment plan and ASIA diagnosis. So it's the TLEX score can be used to guide treatment that is safe with regard as a neurological status of patients treated with thoracolumbar trauma. So kind of more of at least my training bias, we were trained to use kind of the AO spine classification. It goes into the A, Bs, and Cs, where the A's, the first letter is kind of talks about morphology, A being your compression, that includes your burst, and then B being a tension band injury, with C being displacement and translation. There's a modifier for neurologic status from N0 to N4. From intact to complete spinal cord injury, and then NX being that it can be assessed either their own spinal shock or some other particular reason, and then case-specific modifiers, the M1 being indeterminate injury to tension band based on MRI, and then M2 some other specific comorbidity. They have some ankylosing spondylitis, DISH, rheumatologic disease, or osteoporosis. So getting into the treatment plan for non-operative treatment modalities, stable fractures, we'll kind of talk about if they're stable or not. But stable fractures can be braced, so usually your compression fractures or burst fractures, and then surgery for these stable fractures for decreased kyphosis, but there is no difference in pain, PROMs, or return to work, and there is increased costs and complications associated with this. So the never-ending question is for these compression fractures or burst fractures where there's no neurologic injury, is do we need to brace? Do we need to use a TLSO? So there were two randomized control trials by Dr. Bailey and Shamji. The first one, they had basically 1-to-1, 47 TLSO, 49 no bracing, where their endpoint was the PROMs and radiographic at mean of 8 years, and they found no difference in kyphosis. And treating these fractures without any kind of brace led to early ambulation, avoid costs of and patient deconditioning using a brace, and the complications and costs regarding long-term bed rest if TLSO is not available. And then Dr. Shamji, a smaller cohort, it was 12 patients, 30, 33, 34 patients, 12 with TLSO and 11 without any brace. And they found no difference in patient-reported outcomes or loss of kyphosis at 3 years. So getting into the operative management, we'll talk about the unstable, your chance fractures, unstable bursts, fracture dislocations, and then specific about these type of injuries. So usually the surgical indications for treating thoracolumbar fractures is either incomplete or worsening of their neurologic deficit if you notice that there's some cord compression or fracture dislocation, any kyphosis greater than 30 degrees, and then any concomitant injuries, basically needing early mobilization. Another kind of point of emphasis is regarding as the time of surgery. Does it really matter? And multiple studies, either I feel like in standard orthopedic fashion, you can find whatever conclusion you want to find. So there was mixed findings. LaRosa said that in the early group had a greater improvement rate, about 50. Like 42% for complete spinal cord injury versus 90 for their incomplete, and then you had less for the late group after 24 hours. Two other studies demonstrated that there was decreased hospital stay, shorter ICU stay, and fewer like complications due to pulmonary event status in the early treated group, less than 24 hours. And then Dr. Arabai had basically the other opposite, that there was not really huge improvement in their neurostatus after 24 hours. Uh, but their most predictive factor was that if there was an intramedullary lesion on the MRI preoperatively. So getting into the approaches, we'll start with the posterior short segment. Kind of the goals of the surgery is that you get reduction through posture and then stabilize through ligament ataxis. It has some advantages. It's a familiar approach, it's safe. Not really much neurologic elements after you kind of do your decompression, and it's simple. The problem is for these short segments, you have a short lever arm, so you can get instrumentation failure. You can get pseudoarthrosis, inadequate decompression if they have something in the vertebral body that's retropulsing, or if they have any kyphosis. You can't really correct that. Um, Kind of getting into the adjuncts, you could use either bone grafting, kyphoplasty. You could use intermediate screws. And kind of the standard is if you have a fracture there, you go in posterior, you usually go two or three levels above and two or three levels below is recommended. Getting into to this article about Dr. McCormack that was published in 1994, he developed the McCormack classification system that wanted to evaluate if there was any failure in posterior constructs, or at least to see which kinds of injuries would have more failure. Um, and there was a backup study by Dr. Avanti in 2015 that basically kind of said that this classification system didn't really predict anything. So it has kind of fallen out of favor. Um, Getting into anterior surgical approaches, usually the indication is if there's any cord compression due to retropulsion from the bone. Two studies by Dr. Closey and Kaneda kind of demonstrated that you could get better decompression going anteriorly to decompress the spinal canal, and then you can get better maintenance of sagittal alignment by Dr. Sasso in 2006. So when to go combine, usually your our surgical indications would be greater than 40 degrees of kyphosis with greater than 50% of canal compromise with cord compression and neurodeficit. The advantages going front back in the spine would be kind of the getting improved sagittal alignment, you get thorough decompression, and you stabilize the PLC. And Dr. Several outcome studies from going front back. Dr. Pyer had no implant failure 2 years. I feel 2 years is a very short time to evaluate if there's any kind of failure, but didn't demonstrate any failure at the short term. And then Dr. Bean that combined, just going combined versus back only, and demonstrated no difference in patient-reported outcomes, neuro recovery or fusion rate, with greater loss of fixation if they only go posteriorly. So going back to our case, the patient's TLEX score was 8. So he underwent anterior decompression, he had anterior compression injury with retropulsion into the canal and a PLC, which based on the previous study would signify that we need to go front back to stabilize him. So we did a L3 partial corpectomy, fuse anteriorly from 2 to 4, and then back to the posteriorly from 1 to 5. So, in conclusion, thoracolumbar trauma is probably one of the most common spinal injuries. Usually, the higher rate of injury has a higher rate of neurologic injury, especially in the thoracic spine, given its very stable construct, and the thoracolumbar junction being the most common area for fractures because it's more biomechanically susceptible, for better or for worse. As we discussed, classification systems. There's not really one good one. It's kind of using multiple ones and kind of evaluating what the patient has from a neurologic standpoint and from the fracture morphology to determine kind of what you should do. Using compression and burst fractures can be treated non-operatively. The use of bracing has been demonstrated to be safe, and there's no better patient-reported outcomes and no loss of kyphosis. And then kind of the generally accepted surgical indications, your very unstable fracture where you notice that there's a obvious three-column injury, there's progressive or worsening neurologic deficit, kyphosis greater than 30 degrees, and then any canal compromise. Going posteriorly only is kind of the most common one, but anterior, if there is any anterior column compromise, you should be thinking to use anterior based surgery in combination with posterior as well.